that is all I wanted to say about the infection and this one. So
I think we should move on because we made it a point that we start at 7 and finish at 9. So we are eating into Ramesh's presentation. So let me just introduce Ram and then Ram can take over. Dr. Ram Daga again is my former fellow from SGPGI Lucknow. He is now the head of the Department of Surgical Gastroenterology at the prestigious Savai Man Singh Medical College in Jaipur. And Ram very kindly agreed to replace Anand as a speaker because Anand is busy with Kulbhushan, and Ram has agreed to my request to chair Ramesh's presentation. So Ram, maybe you can take over. Ram, आप unmute कर लो.
Yes. Good evening, sir.
Good evening.
Good evening, respected teachers. I think we are already running short of time, so sir can start the session now. Sir, Ramesh, sir.
Yeah, thank you. So I'm going to speak on the step-up approach for necrotizing pancreatitis. There used to be a time when we were postgraduates, I think Vinay would remember, and when we had the occasional necrotizing pancreatitis, there was this huge operation. Patient would be on a ventilator for 2-3 weeks, and then ultimately, invariably, they would die, and very few would actually walk out alive, and those who did, it was considered a miracle. But then we have changed in so many ways. I think what has contributed to the improvement in the management is our understanding of the early fluid balances, which has improved now with the fact that we don't give over fluid, but curtail the fluid and make sure that we balance the requirement between sufficient fluid and over fluid. The second is that the intensive care who have now contributed by their methods of ventilation like non-invasive ventilation, high nasal flow cannula ventilation, NIV ventilation, and using endotracheal tube as a last resort rather than as a first resort, which used to often cause a lot of respiratory infections. Then we have got the appropriate use of antibiotics. And we now know that certain antibiotics are good in acute pancreatitis, and when we require, we use them in the appropriate concentration, and that seems to have improved the outcome of these patients. And of course, our times of intervention. Now, we know that necrosis is associated with a high mortality rate, and this is what is called as critical pancreatitis. And in the very early phase, on the first 2-3 days, a certain number of patients will die. And there is very little that anybody, including critical care, gastroenterologists, surgeons, can do to salvage these patients. These patients have respiratory problems, renal problems, cardiac problems, and they have very distended abdomen. They have rapid multiple organ failure, and they rapidly succumb to the disease. And even today, we have not managed to have an answer to what can be done for this early mortality that occurs within 72 to 96 hours. We can only hope that we can tide them through this time by giving them appropriate fluids, appropriate antibiotics, and taking them to the next phase. As we already said, to remember that acute necrotic collections are less than 4 weeks, WOPN is more than 4 weeks. And we want to delay any planned intervention for necrosis. We used to say that we should delay it by about 21 days. Initially, it used to be that when you have acute pancreatitis, you go in, you open the abdomen, you try to take out the necrosum, and all these patients would die. But then we decided to postpone this to 21 days to 28 days, which is what I was taught when I was an MS postgraduate and when I was an MCH postgraduate. And in that, we had a little more salvage, but we still had a lot of complications, a lot of problems. So then, as we started practicing, as I came to Madurai, and along with others in various pancreatic centers like H. Ramesh, Vinay Kapoor, Sanjay Gandhi, others in Medanta, we all got onto the same bandwagon. And that is, you delay the intervention as far as possible to say, in an average, our intervention days have now increased to about 44 days. So from 21 days has gone almost double to 44 days, and the results have appropriately improved. How do we intervene is guided a lot by the clinical picture, the availability of equipment, and the local expertise and the investigations which are locally. Now, many hospitals don't have an in-house CT. So they have to shift the patient somewhere for a CT scan, and this patient may be on an NIV or on a ventilation. To shift him and shift back causes severe physiological changes, and the patient may actually deteriorate because of that. So I believe that the ideal patient of severe acute pancreatitis should be managed at a tertiary center which has availability of critical care, surgical gastroenterologist, medical gastroenterologist, and interventional radiologist. So you have all 4 arms of treatment available. You should have a CT, if possible an MRI, but MRI is not so essential in acute pancreatitis as a readily available CT scan, where you can just wheel the patient to a CT scan and come back and do whatever investigations are required. And the fact that you should have a critical care unit where you can do all sorts of ventilation, central line management, arterial line management, intra-abdominal pressure measuring, and you must have a constant discussion between these 4 groups of patients, the doctors, because every doctor has his own ego and he thinks that his treatment is the best. But we now have the idea that, yeah, there are people who know something more about critical care than I do. I know a little bit more about interventions and surgery than a radiologist does, but a radiologist can do the intervention more successfully than I can do because I cannot do it. So we have to look at the expertise, and we have to form sort of a team approach and manage these patients with a so all these patients should be seen daily by everybody, so that you have a multi approach, and then somebody may give a pointer that today we will do this or tomorrow we will do this. You must also remember that in acute pancreatitis there will be a severe nutritional loss, so you have to provide nutrition for these patients. They have severe pain, so pain relief has to be given and complications have to be managed. So we avoid surgical intervention in the early, we avoid it in the first 8 weeks actually, up to 35, 40 days, we don't even operate. So what do we do then? Then what we do is that we use radiology as our strong arm. So in the earlier phase, whenever there's a collection, you see, and that is causing the patient is having fever, total count is going up, patient looking toxic, we put in a pigtail into that collection and drain it out. And then when you drain the pigtail, it's not just one time. You have to see that the patient sometimes will become more sick after 2 weeks or 1 week after putting the pigtail, because the collection has become thick and the collection is not coming through that 14 gauge tube that you put. Now you have to upsize the tube to a 16. So the radiologist has to be brought back and told, upsize it to a 16 size tube, and then you can irrigate through that and get all this dirty muck outside. And the antibiotics, first we do presumptive antibiotics which are good in acute pancreatitis. For example, we would use imipenem cilastatin or meropenem in the first phase. But then once we have started getting cultures, we would use the cultures to guide us to the appropriate antibiotic and get the infection control the doctors also into the picture and ask them, you can suggest some a combination of antibiotics based on your cultures, which are not fully sensitive, but the combination may be adequately sensitive. So this is something that is new. That is, the infection control tells you that A antibiotic is partially effective, B antibiotic is partially effective, but when you combine A and B in this case, you may get a very good response. So do that. So we should use their expertise because they are reading about it daily and they can give you some good inputs into these things. Then we can use the CT scan regularly whenever we have a problem. And way to save the cost is that we do a CT screening. We just do a CT on the monitor. We don't take pictures, and we just ask the radiologist to show us the pictures on the monitor, and then we manage with that. So with that, the cost is less than 1/3 of what it would otherwise cost for a full-blown CT. But suppose you want to do an intervention, then you need a full-blown CT because you want to look for pseudoaneurysms, you want to look for collection, you want to look for vascular bleeding, you want to look for all those things, and then we will look at it. And we have seen that once you start doing this drainage of fluid, which is the first part of the step-up approach, the patient's fever comes down, he starts to eat, and he feels better, he improves somewhat. He may then again deteriorate, and when he deteriorates, then what we do is that we do the guided drainage. That we look at a CT now before the drainage, and we sit with that and look at the tubes that we have put in, and we use one of these tubes by dilating the tract, and we use a large cannula, a 13 millimeter cannula through that, and through that we use a 5 mm and a 5 mm suction with a 5 mm telescope. We use both through the 13 mm, and we go in and we wash and remove as much. We go as far as possible to the other side down, and if necessary, we on the other side also we open up the size to 13 and again do the cleaning, and we try to link up the two sides. This is very important. If we can link up the two sides without damaging the vessels, very important that vessels are stretching across the field. So you have to be very careful and gentle. Use a lot of hydrostatic dissection with your fluid under pressure, and you don't damage the vessel. Or you see a large vessel crossing and you think it may be splenic or something, then you clip that deliberately so that it doesn't bleed later. So you clip it deliberately so that it doesn't bleed at a later stage. And once we have done that, what we do is we leave tubes on both sides and we irrigate from one side, and at 100 ml per hour in the first day, and the necrosome will keep washing out the entire retroperitoneum, and all the dirt will come out on the other side. The next day we switch from irrigating to the opposite side and letting it come out from this side. This sort of alternate drainage and this irrigation leads to a good clearing of the retroperitoneum, and you find a dramatic fall in the temperature. The patient improves, and you have to keep looking that the fluid doesn't start showing any signs of blood. This is the most dangerous thing. Nowadays, we don't lose patients to sepsis. Patients don't stay on ventilator long, maximum for a couple of days, and then they are off the ventilator. They die is of bleeding. They are 1 minute fine, and then next minute they have torrential hemorrhage in both the drain, and within 1 minute we have lost the patient. So this is the only this is the common way of death today that we see in acute pancreatitis. And every year we do about 20 minimal access interventions, 15 to 20, and about 2 or 3 patients we lose due to this bleeding. But this is 2 out of 3 who die out of a total cohort of about 300 who actually present to us. We have about 1 case every day new of acute pancreatitis. Out of 300 patients, we ultimately end up losing about 3 or 4 in the early period, for which there's nothing we can do. And then we end up losing these 2 or 3 who do die due to sudden bleeding from massive vessels. But of recent past, this bleeding has also decreased because we have understood that we can proactively clamp the vessels with clips and stop the bleeding, and that if bleeding starts when we see when we are doing the lavage, what we do is we come out, packing the area, wait for 48 hours, and then go in and unpack, and by which time most of the bleeding has stopped. There are people who would do video-assisted retroperitoneal debridement. They will put a big stent into the retroperitoneum and then 2 days later do a little debridement. But this usually requires 4 to 5 sittings of debridement. And if there is a bleeding which is massive at this stage, it is almost impossible to control. You have to rush to the theater, and by that time you may lose the patient. On the other hand, when we are in the theater, and we can just pack it and come out and prevent the thing. And I have noticed that in the last 20 years, the enthusiasm among medical gastroenterologists to do video debridement with all that smelly pancreatic material coming out and that rotten, everything gets contaminated, they don't like it. And they have just handed it back to the surgeons now. So there are a few dedicated people like Todd Barron and all who continue to try to do this procedure, but otherwise everybody has handed it back to the surgeon and say, you take care of it, this is muck, we don't want to try. The necrosectomy can be done by open also, but by and large, open necrosectomy seems to be very much going down because of the large morbidity. They sometimes require long-term ventilation, and they don't do very well in the long term. With open necrosectomy, there are benefits. You have better visualization, you have better hemorrhage control, and you can just finish with one intervention, But the problem is that the patient may go on a ventilator for a long time and may have a massive wound, which will take a long time to heal. And then it will form an incisional hernia, which has to be repaired at a later date. Laparoscopy avoids all this. It avoids the inflammatory response. It decreases the hernia risk, and you have access to the entire abdomen. You can do high speed irrigation and remove all the things. So the minimal invasive therapeutic option has been designed where the New Zealand group has said it is a VRP classification: visualization, route, which could be percutaneous, transperitoneal, and purpose: drainage, lavage, or debridement. And so the percutaneous catheter drainage has really revolutionized the management of pancreatitis by giving us this intermediate option. So from managing the patient's fluid and antibiotics to a major surgery, we have this intermediate option where we can put in multiple pigtails. Sometimes we have got as many as 3, 4, 5 pigtails in a patient. And I used to say that these patients look like Bhishma. They, on the day when he's lying, with all the arrows sticking out of him in the battlefield, they have so many tubes. But sometimes these patients never require a surgery. With multiple tubes, irrigation, they settle down, and then you can remove the tubes one by one, and they'll go home without a single operation. We have got quite a few of these patients. And the PANTHER trial, of course, all of you know, which was the first one to advocate the time up. But I must say, to our credit, we had done this 10 years before the PANTHER trial. We had started doing minimal access necrosectomy, putting pigtails and not operating and delaying it to 42 days. And our results had improved. And so we did not find that this trial was a surprise, because we expected these results, because we have been practicing this for many years prior to I did my first minimal access necrosectomy in the year 1999. So you can see that we have done it for 25 years, and this trial was started in 2010 and then reported. So we had already been doing this, and we had found very good results with much better things. And as you can see, when you look at endoscopic drainage with surgical necrosectomy, in open surgery, there's an 80% mortality. And so it is not a good mortality or complication. So open surgery early is certainly out. Late, avoid it. Try to do by minimal access. The Liverpool also believes that minimal access gives better with mortality odds risk reduction by 73%. You have the tension trial, and there they found that if you use the step-up approach, there's a hospital stay is reduced by 16 days, and pancreatic fistula is reduced dramatically. And new onset cardiovascular failure and persistent cardiovascular failure is also reduced. Then you have the MISER trial, which shows endoscopy versus minimal access, and here they found that the endoscopic had a slightly better than the minimal access. So they had advocated the endoscopic, but as I said, the endoscopic takes multiple sittings, is expensive, is difficult to perform, and so most people have gone on to the minimal access and not the open surgery. The open surgery, I can see, has significantly so this is the algorithm that can be followed. You have suspected necrotizing pancreatitis, you temporize with antibiotics, they may resolve and no more treatment. Rare patient may go for laparotomy because there's a viscous perforation or there's an abdominal compartment syndrome. There's ongoing sepsis, percutaneous drainage or endoscopic drainage, one of the two. Percutaneous is what we prefer, because endoscopic means you're pumping gas into the abdomen, the bowel becomes bigger, the patient is immediately sicker after the endoscopic procedure. So we prefer the percutaneous with the radiologists. They do that, and if they can control the infection resolution, no more treatment. If there's ongoing sepsis, then we can do re-intervention, putting percutaneous drainage accompanied by maybe endoscopic drainage, or we can do video-assisted retroperitoneal drainage, endoscopic debridement, and minimal access debridement, which may lead to resolution. There's ongoing infection, we usually repeat the ward and endoscopic debridement, and they settle down. With this, we now, out of 300 patients who come to us with all stages of acute pancreatitis, We do these percutaneous interventions in about 100 of these patients, approximately. We do the minimal access drainage through these ports in about 15 or 20 in a year. And in only 4 or 5, we would go on to actually an open or a more major debridement because the endoscopy can't reach everywhere. Of those 4 or 5, we lose 1 or 2 to bleeding. We don't seem to lose the others to bleeding. It's only from this last bit of open growth. And so the mortality is this 2 or 3 in the last group, and the 2 or 3 in the beginning who come with acute renal failure, cardiac shock, ARDS, and who never cross 2 or 3 days in the ICU and die. So the day has come that acute pancreatitis has to be managed by minimal access techniques, has to be managed by a step-up approach where you judicially use antibiotics. Everything is done to postpone the intervention as far as possible. This is the aim. You postpone the final major intervention as far as possible. By that time, the tissues that have died, the necrotic tissues, have stabilized, and they will come out easily with just irrigation and teasing, and the bleeding becomes significantly less, and the patients do well. Thank you very much.
Ram.
Yes. Thank you, sir, for summarizing it in such a concise way. Now we all know that things have from aggressive open surgical approach. Now things have changes to for management pancreatitis. Things have changes to step-up approach. Just a minute.
So, Dr. Shastri, maybe you can.
Yeah.
Yes, sir. So
Yeah, I think we're running out of time. I just want to summarize, just take the pearls of, again, what Dr. Ramesh was saying. The step-up approach, what are the basic principles? The basic principle is to reduce the sepsis load by time and with the least disturbance to the complicated physiology that is happening. See, these are the basic 3 principles, and added to that, it's not always necessary to remove the entire necrosis. And say that is, it's impossible to achieve. That's overambitious. So taking that as an advantage, we distribute the risk over a period of time, assuming that sometimes, even with the first intervention, that may be enough. You may not need to go to the next intervention at all. I think that is the basic principle of the step-up approach, and that has come to stay. There is absolutely no criticism so far about the step-up approach, and that has saved a lot of lives. It's very important to remember the principles. How it is executed would depend totally on the local resources and your own expertise. I think this is all the comment I wanted to make. It's time, Dr. Vinay.
Yeah, Ram, anything?
Sir, only thing that we still don't know what are the endpoints of this conservative management. When we have to change from this conservative treatment from percutaneous drains, from laparoscopic approach to open approach, what is the endpoint? We still don't know. We are losing a subset of patients with this step-up approach still, because we still don't know when we have to convert to open surgery or when
we have sort of found that very rare. I mean, the conversion to open surgery is extremely rare. We use the same ports, or we find other ports. Once we find a collection, we place the ports and then we enlarge the openings. And so we don't even use the standard, transperitoneal or ward to do that. We use the percutaneously placed catheters. We put a guide wire through that, and then we use the Amplatz dilator from the radiologist, and then we put in a 13 mm port through that, and then through that we put one cannula with which we can suck or thing, and a 5 mm telescope. So use the 5 mm telescope and through one port. So this is what is our routine, and we rarely now really do a full open necrosectomy unless we find, when we have gone in, that this necrosectomy is sitting on a very major artery and we are unable to clear the artery. Every time we touch it, there is a little bleeding. Then we say, okay, today we have to open this and clean, because this artery, if it explodes in the minimal axis, is going to be death within 1 minute. So there we abandon. So this, as I said, in a year, maybe once or twice we abandon this. And some of these patients are the ones who bleed later on also.
Sir, may I know the experience of other people in the house? Shastri sir, Kapoor sir, how many actually you have to convert to open in your practice?
Again, as Dr. Ramesh is saying, it's not necessary to convert to open. It all depends on, see, it's such a varied picture. If you have multiple locations, necrosis in multiple locations, and it's not possible to achieve, through 1 or 2 laparoscopy reports, definitely you would like to convert, and the patient has clinical sepsis, a deteriorating situation in spite of the first 2 steps. So that would be the indication. How to identify that step is basically a patient who is not improving or he is worsening. See, the absolute criteria are basically of sepsis. Same of the patient is improving, he starts accepting feeds, he doesn't run temperature, and his glucose is coming down. All those features you would be monitoring. It is those ultimately the clinical pointers which would decide in favor of changing your approach from percutaneous to endoscopic or laparoscopic or open. You have to take multiple points into account. It cannot be condensed to 1 or 2 points.
Sir.
The only other situation I would say where probably you may prefer an open approach is that if you have a doubt about the colonic involvement or viability, and you are thinking of creating a ileostomy, because if the ileum is very thickened, very edematous, it may be very difficult to handle it laparoscopically, and then I would prefer to hold it with my finger rather than with an instrument.
Completely agree with Vinay. What we do is, in this situation, we put in drains and start the irrigation. When we start seeing the motion coming, then we do a contrast enema of the colon on the CT scan with a retrograde contrast, and we see a little leak. We know now that we have a colonic fistula. Then what we do is we make a small opening on the right iliac fossa, bring out the ileum and make it as a loop ileostomy and divert the motion. And remember, when your patient has become perfectly all right, don't just close the ileostomy, because the colon that is in the necrosis would have become fibrotic and it will not work. So you have to do a subtotal colectomy and then bring the ileum to the descending colon or to the sigmoid, and then do the anastomosis there to a well-vascularized segment. And you should remove this one which is caught in the pancreatic necrosis.
Yeah, just a word of caution for all, especially young colleagues, that it sometimes may be very, very difficult to handle the jejunum for a jejunostomy and ileum for an ileostomy. And they have to be handled very gently, and it may sometimes be very difficult to bring a loop of ileum out, especially if the patient is a little obese. So we are at 9. I think we will close. As I said, we would like to start at 7 and close at 9. So I would like to thank Dr. Shastri for agreeing to moderate, all the speakers, all the chairpersons. These are some announcements. Those of you who do not know about Jaipur Surgical Tutorial, this is every Saturday morning 9 to 10 academic activity. If you want to join, please send a WhatsApp message to my colleague, Dr. Anand Nagar, who manages the Jaipur Surgical Tutorial. That's his number. And we have started another activity because colleagues from Africa, they were not able to join Jaipur Surgical Tutorial. It's very early morning for them. So primarily for them, we've started a Jaipur Surgical School Friday afternoon. This is being managed by my colleague, Dr. Kailash Kodia. So please send a WhatsApp message to him if you want to join. So once again, thank you everyone. And we meet at the same time tomorrow, 7 p.m.
Thank you. Very nice session. It's been a pleasure.
Thank you. And special thanks to Kulbhushan for agreeing to chip in at the last minute to replace Anand. Anand was busy today. And okay, bye. Good night.
Bye.
Bye. Thank you, sir.